thanks, Nermin, for this organization and also kind invitation. Actually, and also thank you for giving the easy job to me as because I am the guest. But she really very well did her own job. Well, actually, you have seen or listened a patient whose seizure started at age 4, but now he's almost 20 years old and having very frequent seizures, always nocturnal, and we have seen the seizure. These are impaired awareness, focal seizures with impaired awareness with some automatism, starting with the right limbs tonic posture, but then followed by hyperkinetic automatism. And they are very short, which implies a sort of frontal lobe, a motor network involving orbitofrontal, anterior cingulate, insular, we should always put insular area, and also motor cortex, and sometimes anterior temporal area. So if we want to evaluate this patient, we should be dealing with this network. But on the other hand, we have not seen EEG, we don't know about the EEG, so it's difficult to lateralize, but it could be left side, I'm not sure. We should be cautious with this type of frontal lobe seizures, but it could be. But I think the localization, either insular or frontal lobe. And again, thinking about the etiology, usually this type of scenario is related to a cortical dysplasia, which starts early age and then continues. Sometimes they give a break for a while, but then it continues afterwards. And he has already used 4 different anti-seizure medications without any success. So how can we add another one, actually? My dear colleague started saying something totally against surgery, but she did not mention much about how much we expect that this patient can improve with an additional drug. But we'll see. So I will also start with the medical resistant cases because I know that there are young people, there are residents among us also. So our primary goal is always to relieve them from seizures, to relieve them from, if possible, the drugs, the side effects of the drugs, and if possible, all drugs. And we want them to have a better life, improved life. We have certain treatment options. We have pharmacological treatment, as all you know. We have surgery, we have stimulations, we have diet, behavioral therapies, and some others that we don't use much. And this is the famous, actually, study that we can share now. Actually, my colleague also shared, I think, that one. This is an old one from 2000. But here you see, if you give the first drug, the appropriate drug, you almost control the patients, 50% of patients' seizures. But then, if you say that, okay, it doesn't help, let's try another one, it goes to 13. Let's try the third one. It is only 4% of patient population that you can control. And here we have 36% of patients who cannot be controlled with the anti-seizure medications. And the same group, Brody group, increased the number of the patients, now 890 patients, and now we are 2006. But still, with some additional drugs, but still the number of patients who are not controlled are 35% of, again, population. And they say that better response in adolescents and elderly. Again, the same group with the Brody's group. Now it is 2012, and it is green neurology with a high impact factor. And the number of patients is now more than 1,000. And still, with additional new drugs, still we have almost 25% of patients are not controlled. And they also discovered 4 different types of outcome. And these are the pattern D, which means that they can never be controlled on drugs. So he wrote a review saying that despite the introduction of new medications over the last 20 years, still 30% of the patients remain uncontrolled. And this is the last study, which is the newest one, 2018 now, and this is JAMA Neurology. They included all new anti-seizure medications, and look at the figures. Again, with the first appropriate drug, again, we can control 50%. But then the second one, third one, fifth one, fourth one, the number of patients who can be controlled are getting less and less, and it's almost zero here with the seventh one. So it is obvious that despite the new medications, newly diagnosed patients will not be better. So that is their conclusion. We need better drugs, especially disease-modifying drugs for those kind of patients. Okay, now we are sure that there are a group of patients who cannot be controlled anti-seizure medications, whether you try second, third, fourth, fifth, because these are the studies here we can easily see. So who are those patients? We have a definition. It may be defined as the failure of adequate trials of two tolerated and appropriately chosen and used anti-seizure medicine. Now we don't say anti-epileptic. They are not anti-epileptic. They are anti-seizure medications, whether in monotherapies or polytherapies, to sustain seizure freedom. So we have this definition, and the patient presented here is very well fitting this definition. And again, my colleague also showed the same picture, but there are different factors, many different factors behind the drug resistance that we are not really aware of. So that's why we cannot solve all the problems with these definitions. And the other point, these uncontrolled seizures, they can cause cognitive, behavioral, and psychiatric disorders, social problems, not only for patients, but also for the caregivers. There is a huge economical burden behind this, and the most important point, the mortality rate is 5 to 10 times higher of general population. And there is a risk of SUDEP, sudden unexpected death in epilepsy. And this risk is 0.00 in newly diagnosed epilepsy, but it is much higher in epilepsy surgery candidates, which means drug-resistant cases. So we should be aware of this SUDEP, the risk of SUDEP, not only us, but also the parents and the patients. This is the most important point that we should be caring of. Again, my colleague very nicely mentioned about this point. While we are dealing with the drug-resistant epilepsy, we should really think about this condition, because we have many referrals all over, at least from our country, at least for our center, because these patients are drug-resistant and they can be candidates for surgery. But are they really drug-resistant? So there is a concept of pseudo-interactability. What is this? It could be misdiagnosis. It could be inappropriate or inadequate drugs, or non-compliance for several reasons. But of course, there are natural drug-resistant epilepsy that we have to admit. And these are some examples that, because of time limitations, I will just try to show them all together to you. And I'm sure that you will immediately recognize all these patients, and also it is written there. But the most, the condition, the paroxysmal neurological condition that can be misdiagnosed as epileptic seizures are the psychogenic non-epileptic seizures. And really, almost every week, we have at least 1 or 2 patients on our video EEG monitoring unit that we diagnose psychogenic seizures, although they are already on 4 or 5 different anti-seizure medications. So we should be very careful as a neurologist on this issue. So this is misdiagnosis. And I will share my favorite patient with you here and ask you, what do you think about this? This is a young girl who has convulsive episodes whenever she has a sudden pain or whenever she was being drawn blood. So we learned that she needs to be drawn, and we asked her to come to the lab, to our EEG lab, and to do this procedure there. And she accepted, and now we are drawing her blood. And at that time, she started to say that she doesn't feel well, she feels bad, she started to breathe, and she said that I'm leaving, something like that, here at least. And our nurse is asking, where are you going? She cannot answer at that point. She's a little bit pale, and her head turned to right side, the eyes turned to right side. She started to be stiff, left hand, left arm flexion, right arm extension, but it is contracted. And now head and eyes turned to the other side, and then came to the neutral position. And this is the tonic phase for figure 4. And it continues. What do you think about this patient? The first question should be, is this an epileptic seizure? If yes, what type of seizure, focal or generalized? Pardon? You should not say. Don't speak. Any other person, but not Nermin. Tell me, what is this? Now, the second episode starts. Is this a seizure? Huh? Pardon me? What is? Syncope. Why? Why? How did you make this diagnosis? Is it only history, but you didn't see anything on the video EG? Focal seizure. Okay, what else? Is it bradycardia or it was asystolia? Yes, 40 seconds asystolia. Yes, you were majority of were right, but not focal seizure. It is a syncope. It is a convulsive syncope. We published this case, and she had a pacemaker implanted, cardiac pacemaker implanted immediately, because 40 seconds asystolia is a unbelievable thing. So that's why this is not a seizure, because of the anoxia. It's a reaction to anoxia. She had this convulsive episode. And all the EEG was just fragmentation of movement artifacts and also some slowing. That was all, but not epileptiform activity. So we should be aware of differential diagnosis of seizures. There are so many. So if we see a patient with difficult to treat patient or medically resistant patient, we should start thinking about if this is a real correct diagnosis or not. Okay, but about the others, it could be a correct diagnosis, but some other things may happen. Just take a look at this young boy. He is 6 years old, the seizure onset 4 years, and he is on 3 anti-seizure medications. And since 2 years, he has been still having seizures, very frequent seizures. Eyes and head is turning to right side with some eye blinking and some hand movements on the left side. Is this a seizure? Is this a seizure? Yes? Yes. What type of seizure? Generalized or focal seizure? Focal seizure. Lateralization or localization? Left, right? Just let's save the time. I will show you the EEG. And MRI is normal if you want to ask MRI. If you say focal, MRI is normal. But let's look at the EEG. What do you think now? This is absence seizure. Yes, definitely. So the diagnosis just changed to focal to generalized. And the medication also changed to we left only valproic acid, 1,000 milligrams a day, and he is totally seizure-free right after, and then seizure-free and drug-free after 3 years, because it is just subsided. So it is just the usage of inappropriate drugs, but not resistant patient, medical-resistant patient. So just not to make this topic long, we should review the diagnosis, if it is a seizure or not, what type of a seizure, what type of epilepsy, what is the etiology behind, consider the compliance, dosage, and suitability of the anti-seizure medication, and check the lifestyle. Please don't forget about OSAS, the sleep problems, and consider the psychological and psychiatric status of the patient, which is also another issue that we should be really dealing with. But yes, we have naturally drug-resistant epilepsies. I call them naturally because they are there. And in majority of them, hippocampal sclerosis, cortical malformations, cortical dysplasias, which I suspect from this case. It could be autoimmune encephalitis, tumor, infections, etc., etc. So we can think about the etiology behind, but what are the options? What can we do? If this is a generalized epilepsy, which is not for this case, but if it was a generalized epilepsy, we can rearrange the medications because some medications are not appropriate for generalized epilepsies. So my colleague again showed you valproate. We should not forget about valproate. It is an old drug, but it is useful. It is useful especially in generalized epilepsies, not these focal epilepsies. And we can think about palliative surgery, which it will be Dr. Bertoli will talk about later on. There are no neuromodulations like VNS, DBS, if you have others, and diet, ketogenic diet, of course, we should be thinking about. But if it is a focal epilepsy with a single focus, then if it is a resectable focus, it should be really referred to resective surgery at once. And if it is multifocal or not appropriate for surgery, then again we can talk about VNS, ketogenic diet, or other neuromodulation techniques. But I just want to remind you, now we learn more and more about genetics, and which helps us to find out new therapeutic options, just think about them. But I'm not talking about this guy, but this guy, if he was really MR negative, could be sleep-related hypermotor epilepsy, which is called SHE as an abbreviation, and some of them could be genetical, so it's just another option. But if it is metabolic, it could be sometimes, not for this guy. Then we can think about if it is GLUT1 deficiency, for example, ketogenic diet, or if it is immune-related, because it could happen at autoimmune encephalitis. Now we learn more and more about them. Then we should try to therapy. It is an immune modulation therapy. It's a totally different therapy with, of course, at the same time, anti-seizure medication. So we should be always concerned about the etiology behind. And these are the other non-medical treatment options with stimulations, different type, and diet and behavioral treatment, and surgery, of course, in the beginning. And here is, if you just, again, my colleague mentioned about ketogenic diet. As I am suspicious about cortical dysplasia for the presented case, we can also propose ketogenic diet, but he's just 20 years old or more, or higher than 20 years old. It is very difficult. I don't know if any of you knows how you can do ketogenic diet. You have to have 90% fat and just 10% protein, and it's just a really devastating type of diet, very difficult for an adult person, and especially if you have sort of taste, mass taste. But it is good, it's easier for the young people, for young children, especially if they are low IQ and so on. But okay, if it is ketogenic diet, again, here is the nice paper, and they show that even with ketogenic diet, yes, the patient maybe stays seizure-free for a while, and it may be longer in some cases, but they have to continue ketogenic diet. They cannot stop it. And again, they also compared those patients with the patients who underwent surgery, and I'm sure here, as a conclusion, they said that resection of the focal cortical dysplasia remains the current treatment of choice in intractable epilepsy, and in some patients, you can integrate this with ketogenic diet, so it may help maybe better, and the outcome could be better. So it could be tried, but sooner or later they will be referred to surgery. And this is one of the recent papers, diagnostic methods and treatment options for focal cortical dysplasia. There is an urgent need for new medical therapies. This is the conclusion, and the key point is an integrated multimodal, yes, tomorrow we will talk about more, pre-surgical protocol ensures optimal surgical results with about more than 60% of patients becoming seizure-free after surgery. We know that with the drug treatment, they will never ever get seizure-free. Even if they are seizure-free, they cannot be anytime drug-free. But for those patients, even we can stop their medication after a while. So if we just look at, because this patient seizure onset at age 4, so the spectrum of surgery in childhood, it is majority of the cases, it is cortical dysplasia, and then comes the other etiologies. And we have this paper with a multi-center paper. It's more than 10,000 patients. We have our patients included in this paper. And again, in children, it is cortical malformations, the major pathology, or I should show it here. And it is hippocampal sclerosis and tumor for the adult cases. So starting, the onset is during childhood, so we will think about cortical dysplasia. And these figures are nicely show the current situation. In the passing years, the number of patients with hippocampal sclerosis is getting down, whereas its cortical malformations are growing up, even not only in adults, of course in adults, but of course in children. In majority of the children, it is the cortical dysplasias, and hippocampal sclerosis are always in the less percentage in childhood population. So thinking about this patient again, that's why I am suspicious about cortical dysplasia behind. And this is now you may say that, okay, because she showed you some complications related to surgery, although they were really very old papers from 2008 and 2009. Now we know, actually Bertel is also here, our neurosurgeon. He will talk about maybe later on, but the complication rate is really very, very low for epilepsy surgery. And if you want a controlled, randomized, prospective study, it is here. The first one from Pete Engel's group, actually Samuel Weber's group from Canada, coming from Canada. They show that these are the temporal lobe epilepsy cases, the 40-40 in the treatment arm. Only 8% became seizure-free after 1 year follow-up, but for the surgical arm, more than 50% became seizure-free. Actually, this is a huge difference in between. And this is the second paper. Oh, sorry. And this is the second paper related to a randomized controlled trial for epilepsy surgery. This is from United States. The number of cases are really low here. That's why they stopped this study in early phase because of the slow recruitment. But again, even with those patients, the follow-up after 2 years, if they underwent surgery, it is 13 out of 15 are seizure-free, whereas the medical arm, none of them are become seizure-free. It doesn't matter if you add this drug and that drug, but they cannot be seizure-free. And this is the last paper, a very nice paper from India, which was published recently in New England Journal of Medicine. It is again controlled, randomized, prospective study showing that 59 children on medical treatment arm and 57 on the surgical arm. And look at the seizure freedom. In the surgical group, it is 77%, whereas in the medical group, only 4%. And moreover, behavioral scores and quality of life is much better in the surgery group. So these are the controlled studies that can be used as an evidence. And this is also a very recent 2022, just recently published. They looked for the cortical dysplasia if they can be predicted earlier. And then they also concluded that early epilepsy surgery is very important for this kind of patients. Look at the graph with the epilepsy surgery, the outcome. And also the most important thing here is here. They also stratified the duration of epilepsy and age of onset by angle outcome, showing that as early as the patients are underwent to surgery, as better as the outcome. So that's why we, especially during the childhood, for the children, we need to be as early as possible. And these are the key points from this paper. This patient group should be considered for surgical treatment earlier compared to the current standard management. So this is the conclusion. If you want some more evidence, this is the paper just recently published. Unfortunately, although we have all these evidences which supports the beneficial part, the efficacy of surgical treatment, there is a huge treatment gap for epilepsy surgery everywhere in the world. This is a paper from States. They are really very much complaining about. Less than 1% of drug-resistant patients are referred to surgery. Delay between the onset and epilepsy surgery is still 18 to 22 years, and in your case, it was 16 years. It started at age 4, and now the patient is 20 years old. And it is often too late to prevent irreversible social and psychological disabilities. Why? What is this reluctance? Our young colleague mentioned about some figures for you because of the complication rate and so on. fear of surgery. But now we are in 2022. The operation techniques are so improved, even for very young babies, they can be operated very easily. Of course, in well-experienced hands, this is important for everything. Mortality rate is almost zero from surgery, whereas 5 to 10 times higher in resistant epilepsy. I showed you the figures for SUDEP, for example. And another reason for reluctance, lack of information about improvements. But we have now controlled trials showing the efficacy. If you need evidence, data, it is there in PubMed. You can just easily reach them. And they expand. Everybody thinks that cost of surgery is very high. No, they cannot do. That's not true, because lifetime cost of disability, including all outpatient visits, EEG recordings, and drugs, all the drugs, and repeated MRIs, it costs much higher than a surgery. So these are all false negative contra views for the epilepsy surgery. So our goal for infant and children, especially to stop the developmental delay and behavioral problems, because these are usually severe epilepsies. But for adults, it is independence, employment, and driving. So we need to give them to our patients as soon as possible. What did you do? It's almost finishing. And this is a report from ILE task force. They discussed the timing of referral to evaluate epilepsy surgery, and these are some conclusions, but I want to underline here. The referral for a surgical evaluation should be offered to every patient with epilepsy as soon as drug resistance is ascertained, and a surgical referral should be considered for patients even if they are seizure-free on 1 or 2 drugs, but have brain lesions in non-eloquent cortex, because there is a chance of total seizure and drug freedom on one hand, and there is the risk of the others, related to epilepsy itself and the drugs. So as a conclusion, if we have a patient with drug-resistant epilepsy, we need to re-evaluate the diagnosis, re-evaluate the drug therapy, consider the psychiatric, psychological status of the patient, but please consider the surgery at the appropriate time. Of course, there are other treatment options. By the way, we never ever push our patients for surgery. We offer this as an option. We tell them that this is an option for you. There is a chance of seizure freedom, but of course, there is also, these are the risks and so on, and the risks are related to the operation side, the patient onset, and of course the delay. If the duration is too long, there is the risk of failure after surgery is much higher. So we should be always thinking about this and that, and we should discuss about this. And we will talk about pre-surgical evaluation later in more details. And we have other treatment options, but I did not, of course, bring the figures for VNS and the others. Because it is very obvious that VNS cannot be take the place of especially resective surgery, because only 50% of resistant patients have decrease in seizure frequency with a 60%, I can say. So, but if the patient is not a good candidate for surgery, but of course there is an option for VNS and the others, but if they are really single focus in a not eloquent cortex, then they are really good candidates for surgery. So I just want to remind you about our surgery course. Every year in January we do it, and you are all invited to attend. And thank you very much for your attention. Shukran to all of you.